Hello and thanks for joining us on Relational Practice, a social work podcast. I'm Dr. Jodie Park.
And I'm Mackey, and we're both private practice social workers here in New South Wales, Australia. We work in the fields of child protection, out-of-home care and trauma. And today we're recording this episode on Newland.
Thank you for listening. We would love for you to subscribe, rate and review our podcast and connect with us on Facebook, Instagram, YouTube and via our new web page, Relational Practice, a social work podcast.com.au, all one word. We'll be adding content and videos to all of the platforms regularly. Oh, do you want me to do that bit too?
Sure.
Okay. And as always,
I was just enjoying listening to you.
please send us, God, why would you though? You hear it so often. And as always, please send us any practice stories, questions or comments to relationalpractice01@gmail.com. Now today we have a very special guest, Professor Joanne Spangaro. Welcome.
Thank you.
Let me tell you a little bit about you, just in case you didn't know. Okay. So Professor Spangaro is a distinguished researcher and academic leader in the field of social work. Her career is defined by a deep commitment to evaluating responses. So you know how we had two bits?
You like the AI one, don't you?
Well, I only
was just thinking, I don't think I used the word distinguished. How interesting.
You didn't. So I just used a bit of both.
I like it.
I used a bit of both. Okay, so her career is defined by a deep commitment to evaluating responses to gender-based violence and intimate partner violence through both frontline practice and high-impact systemic research. Her research and teaching has been built on 20 years of social work practice. She has conducted 4 studies on routine screenings for intimate partner violence and advises state and national governments on sexual and domestic violence. And we are so happy that you agreed to join us today. Thank you.
Such a pleasure to be here.
Well, that's nice. That's nice that it's a pleasure. Thank you. All right, so we want to talk today a little bit about, about your... It's kind of early research for you now, isn't it? The domestic violence screening tool.
Yeah, it is. Although the last piece of research I did, most recent, was to look at screening and the potential of it in refugee settlement services. So early, but yeah, it's been a really constant theme.
For the last, 20 years?
Well, yeah.
Great.
Mm.
I mean, I think it would be great just to kind of, and that's, I guess, why we asked if you would join us, to talk a little bit about that, about your research and how it has actually influenced practice, I think, in terms of domestic and family violence. Is that okay?
Yeah, absolutely.
Take it away.
I thought you were thinking then, Joe, like, no, that's not okay. What research influence practice?
Absolutely. 100% it has.
So the background to routine screening for domestic violence is that when it was first introduced in New South Wales, at that time I was working in a policy role for New South Wales Health, and it became time to review the statewide policy for domestic violence. Actually, I prefer the term intimate partner violence because I think it's more precise.
Yeah.
And I think it's the violence between partners that is the most lethal.
Mm-hmm.
Typically towards a woman from a male partner, but equally men can experience it. I think it's different from abuse from children to their parents and from parents to children. I think they're a really different dynamic. So I think it's a really, it's a good term.
Yeah, I agree with you. I definitely agree with you. It's such a different dynamic, isn't it? And whilst it's still classified as domestic violence, domestic and family violence, yeah, I can see why it would be. Why intimate partner violence is it's kind of more descriptive, isn't it? It's this is what it is.
Yeah, and it's much more useful to be clear about.
Yeah,
and where you know what the dynamics are. And yes, we spoke earlier about the use of language and how language isn't neutral. And when you make that distinction, I guess I go into a curiosity around, have we done this intentionally to kind of dilute the impact and the blame too of where it should sit and the severity of impact. Yeah, because it's not family. A lot of people talk about family violence. It's not families that are violent. Yeah, it's individuals within that setting, in that system.
Yeah, I like it. I like it too.
So at that time, when I was in that policy role, we cast around to see what the evidence was saying and wanted to really value add. And at that time in particular, routine screening for domestic violence was something that was being built into policies there. There was a lot of research coming out about it. And it's got a really strong rationale, particularly if you're thinking about the health setting context, which was where I was working at the time. So we know that most women who experience intimate partner violence don't rock up to intimate partner violence services. And it is predominantly women, so I'm just going to use that as a bit of a shorthand, not taking away from any men who experience abuse. Also, most people use a health service at some point, so it's a way to identify hidden abuse. We know too that people who experience intimate partner violence are using health services at a higher rate. They have a lot of associated health conditions, especially EDs, emergency departments. We know too that most women who experience abuse don't just spontaneously disclose their abuse. They need to have, they need to be really supported and feel really safe to do that. So we need to come out and actually ask people the question, not just assume we're here, you're experiencing a problem, you will tell me about it. The term screening isn't really a particularly accurate way to describe what we do. It comes from a public health sort of approach. And in the public health approaches, screening is something you do when you've got a very robust test and a very good, clear treatment. We don't have one single robust test for domestic violence because it's up to people to decide if they feel safe enough to tell us, which might vary day to day. And we certainly don't have one intervention for domestic violence. So that's been a contested issue. Some people call it routine inquiry. Screening has just kind of been part of what in this state is used in the policy and it's stuck.
Yeah, I've always kind of thought it was called screening. Yeah, right. But I can see why people would be, why people would have some questions about the language.
And I think particularly people who come from a public health background who get very tied up in knots about doesn't meet the criteria.
The medical model here.
Yeah.
And this isn't strictly fitting in this box.
Yeah. Yeah. But I think what's important about it is it's routine. It's part of your practice. You do it with everybody within a certain prescribed set of, criteria and policy and protocol. You don't just do it because, she looks like that might be happening. She's the typical bullying victim. Survivor. Exactly.
I've got nothing valuable to add.
That's a question though about an age, kind of, what's the age that you would start screening?
Yeah, so in the New South Wales Health Policy, which is this state, says women 18 years and over, and for women who are using an antenatal service or an early childhood service who might be younger than that.
Okay.
Yeah. Yeah. And I think it's good to have a fairly contained window of age. Doesn't mean it can't happen to people who are younger or older, but it means if you're going to put that effort into asking everybody, then you need to kind of pitch it where the risk is reasonable.
And I think capturing anyone using an antenatal service that might be younger, that's a good kind of safety net.
We know that they are the ones who are more likely to be in an abusive situation if they're younger because they're going to be more vulnerable. Yeah.
So what used to happen before the screening tool came into practice?
So before the screening tool, the health department in the state put lots of effort into training people, identifying and responding, and lo and behold, there was very little identification and response despite all that training. So there was a reasonably well-trained workforce, but very little identification. When it was identified, there would be referral to social work, and social workers have always done a lot of work around intimate partner violence, including in the health system. It's just that they didn't see very much of it because there was such little identification.
I think that victim survivors, you might find that might be the time where they go into disclose because maybe now they're ready.
Yeah.
Or maybe now they feel like their life is so threatened that they know that they are probably on the edge of being killed.
But sadly, even when there are lots of instances of even when women get the courage, they're in an ED, they're there because of an injury, because of abuse by a partner, and they say, this is what happened, when they go back later on, it's often written down as alleged domestic violence. And it's just like, why is it so hard to believe people?
Yeah.
Why is it so hard to believe women?
That's actually a really good point. That's a really good point.
Yeah, I've heard of instances where women wanted to take legal action retrospectively or down the track and know that they went into an ED, know that they gave a clear account of how the injury was caused, and then there's nothing, it hasn't been recorded.
Wow. Okay.
Mm.
Wow, that's terrible.
But it makes sense, doesn't it?
Yeah.
Think about the context of suing or being sued, you know, being told that you're not professional or you've done, you know, we use language as a bit of a shield, don't we, to shield us from stepping in. And I think so many practitioners would say, well, of course I believed her, but
I had to cover.
You know, the policy says, or my training says, or my supervisor says, I didn't see it, so I can't write it. So I use that word alleged, and it feels safer for practitioners. I don't think it's right, but I know I've used that word 100 million times in practice.
And I think in some instances it's the right thing to do.
Yeah, I mean, it's hard though, isn't it? Like if someone was sitting in front of you or lying in front of you and they said, this is what happened to me. God,
there's another way to document.
Yeah,
Serious.
absolutely. Yeah. Instead of saying alleged, because it all,
Rose said,
open
your quotation marks and write down exactly what Rose said. You don't need to interpret it. You don't need to put your value on it, your bias on it. You just need to write as verbatim as possible that Rose said this.
Well, kind of you are putting your bias on it when you write the word alleged, aren't you?
But if you just, Rose said.
Yeah.
You don't need, I think sometimes we hide behind language and understand why we do it, because I do it too at times. But I don't know that it's helpful for feeling validated, believed. I don't think it's helpful when down the track someone else in a different context, be that legally or, you know, in any of that legal systems, family law courts, children's court, whatever court, that they then see a professional, right? Rose alleged that, as opposed to Rose said.
I mean, do you think it's a little bit of a symptom of the risk-adverse kind of world that we're in? So writing the word alleged, it kind of waters it down. You're not saying it happened because you're just saying this is what they said.
I think it's definitely that, and there's also strains of a long tradition of not believing women and a kind of view that women are likely to make stuff up. Women are vengeful creatures.
That's right, yeah.
You probably wouldn't write allegedly hit by car if somebody came forward that
I got hit by a car.
Yeah.
Yeah, that's exactly right. I mean, same thing for children too. You know, I believe there would still be people that think, they hear a disclosure from a child and think, well, they made it up. They made that up. They're just lying. They just want attention. You know what I mean? Like, and we know, research tells us that kids never lie about being harmed. The same way, if you are going to be, you're in an emergency and you've been harmed, the chances of you lying about what happened are pretty slim.
Well, and you're more likely to lie to cover up.
Yeah, 100%.
Like did.
Yeah.
100%. Yeah. No, nobody hit me. I fell over, or this is what happened, or 100%. Yeah.
So since then, I left the policy role and did a PhD in which I continued my interest in routine screening for domestic violence, what women think of it, what health workers think of it, what happens after they disclose, if they make a decision to disclose abuse, who decides not to. And I've also done studies on Aboriginal women's experiences of it, both in dedicated Indigenous services and mainstream services, and then introducing it in refugee settings. So what I've found over a number of those studies is that on the whole, women who experience abuse and who are asked those questions think it's a great idea. And they have, in my studies, they've been clear that unless the health worker comes out and asks the questions, flags that they know something about this issue, they are not just going to walk in and spill their guts. So the health worker asking is one of the things that gives women courage. And with most screening protocols, there's a little, what they call preamble. So there's a little explanation. You don't just bowl up and ask questions. In this state where we are, it's something like, in this service, we ask all women some standard questions about violence in the home. You don't have to answer them if you don't want to. If you do tell me something that makes me think that you or someone else is seriously at risk, I might have to tell somebody else about it. And it's okay if you don't want to answer. Words to that effect.
I mean, great memory. I was thinking, you just know that. I guess you spent a lot of time.
Yeah. And look, so even before you've asked the questions, you've provided some really important messaging. This is really widespread. It's so widespread we ask everybody. We might know something about this problem here. Be alert that it's not absolutely limited, not absolutely guaranteed confidentiality. So we're not going to catch women out and go, aha, now I'm going to make a child protection report. And we're giving them some choice. They don't have to answer if they don't want to. So it's a critical piece. And then where screening's been introduced, there are different protocols, and there's almost always a standardised set of questions, and they need to be brief. 4 is about the max, and usually people are using what they call validated tools. So you don't have to ask about every kind of behaviour. Did they do this? Did they do that? We certainly don't say, have you experienced domestic violence? Because a lot of people don't know what that is, or if what they're experiencing is. So you need to find a couple of kinds of behaviours. Hit, slapped, hurt in other ways is what gets asked under this state health jurisdiction. I've been involved with some colleagues in developing a newer tool in which we recognise that fear is really common, control is really important. So we've validated that. It's called the ACTS tool. Has your partner done anything to make you feel afraid, to control you, to threaten you, or to slap or otherwise physically hurt you, which we think is great. And again, rather than a yes/no answer with that tool, we give them a sliding scale of never, rarely, sometimes, fairly often, frequently. Because in fact, what I found in my research was that women never just say yes or no if you ask has this happened, yes or no? They don't say yes. And often what the health workers were left with was like, yeah, a bit, but only once, and he didn't really mean it, and it just wasn't a really big deal. And so health workers left going, I don't know, is it a yes or a no?
Yeah, right.
So if we can use that kind of sliding scale, we're not asking women to jump right in the deep end, so they can just go, oh, sometimes, or once. And then there's a way to score that, and if you reach kind of a certain score, you kind of decide it's in or not. So those sorts of tools are really supported ways for people who want to use screening to do it and in a way where they don't have to interrogate anybody. They're not taking somebody's statement. They're just asking enough little questions to enable women to say something if they're feeling safe enough to do it.
And is that tool now being widely used?
That particular tool, we used it in the refugee study, and I'm not sure where else it's been picked up. It's been made available in Victoria, along with other tools. They're kind of just starting to introduce screening in some of their services. But, there are a range of tools, and we're hoping to see that one get picked up more widely.
Right, yeah.
Yeah.
Because the focus on harm and control, it's so important to kind of explore that.
Yeah, there's great research that says, not mine, that says if you only get the chance to ask one question, ask about fear. If you're in a setting and you're not kind of in a position to, use more of a protocol, just ask about, is somebody doing something to make you feel afraid?
Love that question.
It's good, isn't it?
It's a really good question.
Yeah.
And I think the people that listen to us, we know they come from all different, I think there's a lot of child and family social workers who listen to us, but I know there's people that come from different fields as well. And that question could apply to anybody.
Yep.
Yeah, right. That's a great question.
Yeah. So women are really on board with it, and generally what you find is that the women are ahead of the practitioners. The practitioners are going, I don't know if we should do this, we're going to offend people, we're opening Pandora's box. And one of the papers I ended up publishing, I titled Pandora Doesn't Live Here Anymore, because what we found is that with time, with a bit of experience, with some training, a clear protocol, clear referral pathways, practitioners they just need a little bit of practice. And of course it feels odd and awkward when they first start asking the questions, but then the first time somebody actually discloses to them, the lights go on, they suddenly realise that it's really actually all worthwhile. And quite a few of them have told me in focus groups and interviews that at the time, a woman said, no, everything's fine. But then, particularly if it's in an ongoing relationship, some months later that woman will come back in and go, oh, you asked me those questions a few months ago. And I said, well, actually. And so they've really planted the seed, and established themselves as a safe person.
And this might be a service that could assist in that way. And I think the later screening tool you talked about, I like the variety of questions because it kind of gives you a hint into the perpetrator tactics, doesn't it?
Yeah, it does.
Is it just control? Because we know often people talk about, well, I don't get hit. He doesn't hit me. But the coercive control is certainly something that has existed in their relationship throughout. So I like that it is also a little bit about insight into the perpetrator's tactics.
And we've talked in other podcasts, we've talked about intimate partner violence a lot in this podcast. And I know we've said before that it would be great to have this kind of universal education for society that basically says this is what violence is, this is what domestic violence is, this is what intimate partner violence is, this is what control is. It's all the same thing.
Yeah. And because we know that for a lot of people, they don't feel safe enough to say anything. And all of the good protocols, they'll produce a little tiny wallet-sized card. Often it's got flowery images on the outside, but then some key contact numbers. And the practice is that you give it to people regardless of how they respond. And say, that's fine. We give this little card to everybody. You might know somebody, you could give it to, or if you don't want to take it, you can just leave it in the waiting room on the way out. So that you're giving them permission to put something in their hand, to take something with them, to absolutely get rid of if it might not be safe to have it with them, but to have it as a resource. And I've had women do really different things with it too. Tell me that one of them said she tucked it under the cutlery divider because she knew that was a place where her partner would never look. But another one said she stuck it on the fridge because she wanted her partner to know people are asking about this stuff. So women are making decisions about their safety all the time. There's such a spectrum of risk and abuse, and generally women have got some idea about that. It's not just one thing.
No, yeah, absolutely. I had a question and now it's gone. It happens frequently. It's okay. Keep going. It'll come back.
One of the things that I was really interested in was what proportion of women are saying no when really it's yes. So in one of the studies I did, I got the health worker surveys, and health workers gave out surveys to women, I think something like 12 weeks after they'd had their first experience of being asked about abuse, so we could get a bit of a sense of then what happened. And I asked them to give them, there were two different surveys, one for women who'd said no, which was most of the women, and one for women who'd said yes. But we included in the survey for the women who said no a question which was, you got asked these questions. In your response, we know that you said, that nothing was happening. This is now a survey under conditions of confidentiality, because we had big locked boxes out in the waiting room, so they knew it was like, put it in there, they posted in yourself. In fact, at that time, were you, was anybody making you frightened, hitting you? And I found that 14% of the women who'd said, no, I'm fine, were actually it was a yes.
So they teach yes on that second survey.
Yeah, because the survey was actually confidential.
Yeah.
Whereas screening isn't. Screening is I'm asking you.
That's right.
To
You have to answer.
Maybe what I want to know your phone number.
Yeah, that's
Where
right.
you live.
Yeah, exactly. And I'm probably, if it's really going badly, typing it into a computer, so you just feel like that's on some mainframe computer somewhere, and everybody's got access to it.
Be terrifying.
Would be really amazing. Anybody discloses it all.
Yes. Yeah. But I can see, you said before, your research has found that by asking the question, people are more likely to disclose.
Oh, absolutely.
I can definitely see why that would be so powerful.
Yeah.
To have someone asking you about it, because you don't need to use the language yourself. You can just use the language in the question, and then when you can rate it in that way, I know that was a different screening tool, but I like that rating system. Yeah, because again, you're given the words, so you don't have to think about the words. You're giving them,
and you only have to admit to this much, not
100%. Yeah,
which is, I think, is really powerful.
Yeah, I agree.
And if the women who'd said yes, and we surveyed hundreds of them. Well, no, we didn't survey hundreds because it was hard to get them. 23% of them said they were telling someone for the first time.
Wow, isn't that huge?
Yeah, that's good.
Under a quarter.
Yeah. I mean, some of them had been to police and been to court.
Yeah,
it wasn't their secret. They'd used services, but 23%, that was the first time they'd ever told anybody. So yeah, that makes it worthwhile in my mind.
It really does. Really does, because imagine how isolating that must feel for that poor woman who didn't until this moment felt like they could tell anybody. Yes, that's great.
And so in New South Wales, they use it as standard practice in antenatal, early childhood, mental health, and alcohol and other drug services. Antenatal and early childhood because the risk is really high for children, and we know that. Alcohol and other drugs, and mental health because the prevalence is really high. But we know that in particular, the midwives, women who are seeing midwives in the antenatal care feel like midwives are really safe people. A midwife's a trusted person. Yes, you're trusting with your baby, you're trusting with your pregnancy, and so they're really good at asking all sorts of tricky questions. And what was really nice too was that when I interview the health workers, because part of the protocol, a good screening protocol, is that you can't ask those questions with any other adult in the room.
Yeah.
Even if it's her mother or her sister, and she says, "Oh, it's my mother, it's my sister," I tell them everything. Nobody. Or children over 3. Somebody did a lovely bit of research and said children at 3 and over can comprehend. So you either don't ask the questions or you don't ask them that day. Or one of the challenges a lot of the midwives had initially was how to get the partner out of the room. And for a long time I've been saying to the New South Wales Health Department they should split that very first visit, which is when they get asked into 2 and have an exciting first visit where they listen to the baby's heartbeat. And then they have a boring second visit where the partners drop off and don't come. A lot of the midwives got very good at asking the partner to go down the corridor and book the next appointment or inventing urine tests to do. But it's still a challenge, you really can't ask those with anybody else there.
No, of course not.
And what the health workers also said was that once they get that person out of the room, they often get much better answers to other questions they might have, like, do you have any mental health issues? Is this your first pregnancy? Did you want this pregnancy? Which surprisingly a lot of women do not tell their husbands or mothers or sisters. And so they actually found it to be really beneficial. And it says something about privacy and the importance of privacy as well as family inclusiveness. We need both.
But yeah, I agree. I remember it must have been my second child. It was a visit at my house after my child was born, and they asked my partner to leave the room, and I laughed, and they looked at me and I said, "Oh, here comes the domestic violence questions." And she was like, "Sorry?" And I was like, "That's what's coming." And she was like, "Yes." And I was like, "Oh, all good." But I wondered, I remember thinking how tricky it must be if you're actually in a domestic violence relationship in your actual home.
Yeah.
It was a home visiting program. How tricky that must be for the health workers, but also if you think about devices and tracking and all of the things that we know perpetrators use in their coercive control, how difficult a space that must be. And tricky for the practitioners.
Yep. And in truth,
weigh up safety.
The likelihood of a woman disclosing when her partner's on the other side of the door is very, very low.
Very low.
We know that.
Yeah, absolutely. That's what I was thinking. I was thinking, imagine the health worker goes and that guy's like, what did you say? What did you say? And I think it kind of would just put this that woman in a little bit more danger for that period of time. Well, they're trying, persuade the partner that they didn't say anything.
Yeah, look, I had lots of conversations with the early childhood nurses about this over the years, and I've done presentations, and they just say, we can't ask people to leave the room. So it's interesting that you found one who did, which was pretty bold and what they're supposed to do, but they just have this sense that once they're in someone's house, can't ask someone to leave.
The rules are different.
Whereas I think if you're skilled, you can say, okay, well, we've weighed the baby now and seen how much she's grown. Isn't that lovely? Now, can you, siblings, dad, granny, take the baby out for a minute? 'Cause it's just a couple of things I need to check in, with mum about, and baby's getting restless or something.
Actually, that's really clever. That's really clever, because if you think about, a perpetrator who's trying to come across as, Mr. Wonderful, I'm the best partner and the best dad in the world, then, they're not going to say, no, I don't want to take the baby, are they?
Yeah, it's very hard, isn't it?
Yeah.
I really like too, Jo, what you said about privacy versus family inclusiveness.
Yeah.
Because I think that's something that we've talked about family secrets, and in oftentimes the systems we work in, it's almost like there can be no family secrets, and information gets stored and shared, and, depending on the skill of the worker. But I think back to a conference I was at, and it was a woman with lived experience of intimate partner violence and disability, and saying for 5 years she was having pap smears, and her carer/partner was in the room whilst she had all of her pap smears, and not one GP or nurse practitioner, whoever was doing them over 5 years, had ever blinked. And she was asking, can you, and he would say, oh, but I'm the carer, and they'd go, oh, of course, stay. This is in a different state. But I remember sitting there shocked, one, at thinking, wow, you can even, as a perpetrator, be, part of this medical experience for this woman. And she's asking whoever was doing these exams 5 years in a row, can this just be a space? Because she was trying to find a way. Like, her control was so severe. She said over a period of 6 years, she could not recall being in a professional's space without him being present.
Wow.
And I often think about her when I think about working in family systems and all the research about family inclusivity, and absolutely it's important, but we also need to balance people's right to privacy. And if we're never seeing them alone, how are they ever going to disclose? Imagine that, 6 years, every professional you see. And she was verbal. There was no intellectual disability. Like, this is what she's saying. I have a physical disability. Absolutely. How does that mean then that I don't get the opportunity to speak to a professional without him sitting next to me?
Yeah. Wow. Okay.
So powerful. I remember sitting in that conference thinking, this is something you can never let go of, Rose. The chance to talk to people alone, regardless of intersectionality, of disability, gender, all of those things. Like, people have the right.
But I also think that hiding behind that carer role for that perpetrator just almost legitimized him, didn't it?
Absolutely.
Now, I'm the carer. She needs a carer. I'm the carer. So therefore,
I have a right to be here for all of her pap smears.
But also, therefore, you must be a good guy. How nice it is that you're taking on that role. Wow, that's so sneaky.
The Velcro partner. It's a bit of an indicator, really. That one who wants to just stick like Velcro.
Yeah.
Not a good sign.
Not a good sign.
And I think the pendulum's really swung too far. I mean, I can think of recent encounters with, family members in the health system where there's never been a question that I'd be asked to leave. And I'm just thinking, and now I'll just get up and leave, visiting somebody in hospital, and the medical officer comes in. I just think, this is a private conversation. I don't need to be here. You're entitled to private time with you.
Yeah.
Yeah. Treating doctor or whoever.
Yeah, that's true. I didn't know that, actually. It's It's been a long time since I visited somebody in hospital because I didn't know that. I thought you still had to leave when the treating people came around. Right.
I think it's very dependent on who's treating you.
Yeah, that's true.
And I think they've learned that often patients do better when they've got a lot of family support.
Yeah.
I mean, there's good stuff behind it, but then it's not a big thing to just, to just build it in. The health department here has a whole privacy policy, and for a long time I was chipping away as a research recommendation saying health visits need to have a component that's private.
Yeah, uphold the policy.
Because then there's a component of choice around what you share. For that patient.
It's a very different. I remember learning that really early in my social work practice days when I was a sexual assault counsellor and working with women 24 hours who might be brought in after a recent sexual violence experience. And often they'd come in on their own with the police, but if they came in with a flatmate or a boyfriend, I'd sit everybody down, introduce myself, and then pretty quickly I'd get them out of the room. And I would always say, look, he or she can come back whenever you want them to. It's just a different conversation if it's the two of us. And they never ever asked for their boyfriend friend to come back into the room. And I guarantee it's a different conversation. It doesn't matter how well you know somebody. When you're processing something intense, you need some space.
Absolutely.
Yeah, you do need some space. And it also, I could imagine you would have been quite genuine and you would have been quite approachable, and they probably felt quite safe. I think you would have really good skills in making someone feel safe. So they didn't need that person with them because they felt safe in your space at that time.
And there's a lot of complex decisions to make at that point. You want people to have a sense of control, but very often it's easy for other family members to want to override and take away that choice and control from people.
Because they're helping. They need to feel useful. Or if they've got some experience and this is how it helped them. So we'll do, there's lots of different motivations, I guess, but it's rarely around the actual victim survivor and their kind of voice, choice and empowerment.
All the people feel absolutely disempowered, all really guilty because they didn't protect this person. Do you know what I mean? And so they want to do whatever they want to do. If they are not the perpetrator, if they are the support, they want to do whatever they want to do now to regain some internal control because that's actually about them. To kind of, for them to feel like they can regain some control, so therefore they can be more useful in the situation.
Yeah, quite likely.
Okay. Well,
so I think some of the listeners might be interested in implementing it. This strategy works better if it's a system-wide strategy rather than people going off and deciding it's a good idea on their own.
Yeah.
And, even if it's a small service that people live in, it's really useful to talk to a team about it and get some training, work out what are we doing when a woman says yes. Are we the right service? Is there someone we should refer to? She still needs some choice in that. How do we make sure that if there's a sort of soft handover, that there's an immediate response? There's a lot of legwork to do. So I wouldn't encourage anybody to just wake up tomorrow and go, right, I'm going to give that a go. Because you also need to think about what questions am I going to ask and what am I doing with the information and, what's my response in terms of a child at risk report if I know this woman has children. So it's good to do it as a part of that supported system. And it's also really important that it remains not stigmatising and that everybody gets asked and it's not selective. If everyone within a given criteria here. Yeah. I think New South Wales Health did a couple of pilots in the last few years within emergency departments. And I think I'm still not sure where that is, but emergency department screening is a really big ask because such high volumes of patients come through there and they're under incredible time pressures. So you need to have some pretty tight criteria, and I know I suggested to them that they make it women up to the age of women between the ages of 18 and 35. So that's a kind of narrow, reasonably narrow cast. Not men, it could happen to them, but they're not the high risk group. At 35, we know a lot of partner violence starts to ease off. Doesn't mean it won't happen to people older than 35, but you focus where the risk is, and then you use the skills that you've got from screening to have those conversations with somebody else if you think that there's a suspicion there. So it's really important if you're going to implement this that you do it universally.
Mm. Do you think people could kind of use their own version of that fear question in their individual practice?
Yeah.
I think so too, because then that's a great question. And I guess it's like you would need to make it feel genuine for you. So you would put your own little slant on what words you use. But yeah, I think it would be good. I think it would open a lot, depending, of course, on the role.
Yeah, and as part of an assessment, it's a really, useful question to say.
Yeah.
I'm just in a whole lot of things about you. One of the things I ask about is, anybody in your life making you feel frightened?
Yeah, I could see that would be really useful.
And if you're a skilled if you're a skilled practitioner, a social worker, and you're doing assessment, you've got a way to incorporate that to introduce it naturally.
I think though, as long as you know what you're doing with the answer, if it comes with a yes.
That's right.
Because it can't be yes and then tell me some more, and then you move on to I'm not sure the next part of your assessment, and it just sits there. You need to be able to
imagine
have the skills, the knowledge and the expertise for what you're going to do with it when it comes back with the yes.
Yeah, for sure.
Absolutely. And a good protocol will also be very clear that there's some things you need to say. Thank you for telling yes. What that person did is not okay. I'm going to try and get some help with that. Would you like some help with that? Yeah.
Yeah, what would you like me to do now? What's the next steps? Because that again gives choice, doesn't it?
Yeah.
So a lot to think about. How did your I don't want to jump ahead, so if you want to talk about this, tell me to stop jumping. But how did your refugee research go in terms of?
That was such a lovely opportunity. I was approached by Settlement Services International, which is the biggest humanitarian settlement program in Australia, and they said, this is happening a lot with our refugee population. We'd really like to partner with you and do some research. And so we did, which was fantastic. We got a grant to do the research. Sadly, our data collection period coincided with COVID. And all refugee intakes stopped. We just stranded thousands of refugees in other countries. They were approved with refugee status, got very little mention in the media, and they were just left stranded. So we had to kind of change things around a bit, and we did end up going ahead, and we did it with people who weren't the newly arrived refugees, but who'd been here a little bit longer. And we did a lot of training with them. We had tools in different languages. We got translations made, and we just did a small pilot with them, but we developed a heap of tools for them to take forward, including we had new little cards made and beautifully illustrated with diverse images on them, and had them translated into, I think, about 30 different languages, and had them available in a format where services could just print them off on a colour photocopier and cut them out and make discrete little foldouts for them. So there's a lot of fear in those communities. And, they have kind of fear times 3 because they experience a lot of discrimination. They're very isolated, often from their family. Often women are have left parents and extended family in their country of origin. They're fearful for their partner. They don't understand the system here. So there's a whole lot of factors that reduce even more the likelihood of them disclosing. But the sector really realised that it was still a really important thing to introduce, because they had a number of really awful murders, women who were murdered by their partners. So they're really motivated to do something different.
So we did an episode a while ago, and I think it was the 2024 stats, 58,000 women across the world had been murdered by someone that was known to them, or a male, and women. And so obviously this is across cultures. So intimate partner violence, doesn't discriminate women often. So it is, really, I think, significant that Settlement Services, International asked for some assistance around that, because I think a refugee, that work is tricky anyway for all of the factors you mentioned, but then add in a cultural lens too around possibly sexism and women's place and women's value. What a, incredibly complicated kind of domain of practice.
Yeah, 100%.
It's really complicated, and they're terrified of this being seen as for cultural reasons. It's higher in their community. But in truth, too, we need to look at the role of conflict and war and trauma and dislocation and, how that can really wear people down and the stresses. I'd really like an ecological approach to understanding intimate partner violence, where we see cultural and societal stresses and gender imbalance, but we also do make space for individual experiences.
Yeah.
There are a lot of Aboriginal men who've experienced intergenerational trauma and incredible abuse as children, being part of the stolen generation. Now, nobody comes through that unscathed, and so that kind of model is useful in thinking about all the different factors that contribute.
Yeah, I agree. Kind of like applying this kind of lifespan approach, or not approach, what's the word? This kind of lifespan evaluation, I guess, to kind of put the pieces together as to this happened when you were, 3.
Yeah.
When you were 13, you were doing this. When you're 23, you're doing that.
Yeah.
Can you see there's a link?
Yeah.
Yeah. That would be a great, I think that would be an amazing practice change.
And not all men who use control or physical harm against their partners are lethal,
of course,
predators.
Of course.
We have this incredible spectrum, and in raising awareness around intimate partner violence, we've been a little bit guilty of demonising those people in a way that we think they are all incredibly dangerous people, and some of them are, and some of them aren't. Some of them are 22-year-old young men who are using too much marijuana, but
have a brain injury and a history of child abuse and neglect that spans from 0 to 16 years of age, but then homeless from 16 to 20.
Yep, and might be really amenable to thinking about their behaviour differently and making changes.
Yeah, once they understand their behaviour and once they understand what actually has motivated that behaviour and what benefit that behaviour has given them in their life.
Yeah.
I think it's so much power in helping people put those connections together, because suddenly it's like the lights are on and then they can make a decision to do things differently. But you can't make a decision to do things differently if you don't actually understand the behaviour and the hold it has over you.
Yeah.
Which I think when we kind of talk about trauma processing from that lifespan kind of view, I think that is the power in using that approach, say chronological approach in trauma processing, because it does kind of give people such a different understanding of why they do what they do and why they think what they think.
And then they can step away from self-blame, which isn't an empowering kind of framework to bring.
No, but I guess my worry, this is a worry, my worry is that when we have this kind of, you're the expert, so you might disagree with this. That's okay. But when you have this kind of one-size-fits-all approach to, say, perpetrator programs or to behaviour change programs that doesn't always take into consideration the context, the true context of somebody, then I think you miss an opportunity to actually really understand that behaviour and help that person to understand that behaviour.
No, I completely agree. Yeah. And sometimes the criminal justice response is really appropriate and says, actually, that behaviour is criminal. That's against the law in this country.
Yeah.
But it doesn't mean, we slam them in jail and lock them up and throw away the key, as if that would happen anyway, so really.
Yeah.
But absolutely, we want those behaviours to stop, and that's what women want. They want the behaviour to stop. They often still love that person. They're often really loath to let go of that relationship. That is not the first thing that they want.
They just don't want to be hurt.
Yeah.
They just want to have a safe relationship, as should be their right. As should everyone's right to have a safe relationship where there is this kind of reciprocated meeting needs and this reciprocated, I guess, positive regard for each other.
Yep. Shouldn't be too much to ask for.
It shouldn't be. It definitely shouldn't be. I look at your face. I know you're thinking, you're being Pollyanna again.
A little.
I know. I'm not often Pollyanna, except when we record. Something
always Pollyanna. Jodie, when we walk in here.
Oh,
I think that's okay. No one's going to listen for gloom and doom.
No, that's true. We balance each other out.
I think it's reality based, but got to give people a sense of encouragement and that, you know, there's another way to do it and it will make a difference.
Otherwise, what are we doing?
What are we doing? Exactly.
Yeah.
Yeah.
I would love to see a pilot program that looks at that actually changing, looks at how you can do perpetrator, even if you might not even call it a perpetrator program.
No, you might not.
But how you do that work differently.
Yeah.
Different.
Yeah. Yeah.
Which doesn't mean you're watering down, of course, the behaviours that have happened, because what has happened has not been okay. So you're not watering that down at all. You're not justifying that at all. But it's about trying to give this person the opportunity to make change by understanding why they need to, I guess.
Yeah. My colleague Kelsey Hegarty from University of Melbourne and I sort of kicked around the idea of doing some research in antenatal settings with young fathers to be, and there's a really big need there for something that you could wrap up in fathering, and you could address respectful relationships and how to support your partner to breastfeed and all of the stresses of a newborn. But
and you generally have a motivated person then as well. That's a great time to do that.
Yeah.
Because it's exciting and everyone's kind of like, wow, we're having this baby. Whilst I know that's not everyone's experience, but I think it would be the majority of the experience, maybe. That's a general statement. Of course, I don't know the stats on that. But from my perspective, I would expect it to be the majority of the experience, that people find that time a really kind of happy time where they're kind of thinking about the future and what the future's going to look like.
Yeah. I mean, wanting to be a good dad is a really, really good hook.
I think that's a much better way to say what I just tried to say. Yeah. That's why I think it would be a great time to implement a program like that. Oh, I mean, it's a shame you retired.
I mean, could have worked for a lot longer in this field, huh?
Absolutely.
Yeah, there are lots of other good people doing really good work.
Yeah, of course.
I think one of the other things to remember too is that if you're working with a woman who's experiencing intimate partner violence, that isn't always going to be her biggest priority. It's a really hard thing for practitioners to hear, but there's, we know the intersectionality means that women who are experiencing abuse may also have a mental illness, may also have a disabled child, may also be struggling with poverty, may have her other health problems. And I think it's really important as practitioners not to be ahead of that person and expect that what they will want to do is immediately end that relationship. And it might not be safe for them, but it may still be better than, being homeless and being even more exposed to the whole range of risks. So I think, like with all practice, we really need to go at a client's pace and be with them and not instructing them.
I love that point. I think that's a really powerful point. And I think that's not something I would hope I would think of in the time, like in the moment. But you're right. It might, just because it's your priority as the work, it doesn't mean it is that person's priority for whatever reason. Yeah, I love that point. I'm going to remember that.
In my group, can I ask a question about age?
Yeah.
So you said earlier about, 35 tends to be the age frame where, can't remember your exact wording, but intimate partner violence.
Yeah.
Not declines, you didn't use that word, but can you talk a little bit more around that?
Yeah, it does seem that it does actually decline after the age of 35. And we need to be really careful about saying that, because of course that doesn't mean nobody experiences domestic violence beyond that age. But it does seem to decline. Now, whether that's because women who experience it reach a point in time which they are able to extract themselves from the relationship and be in a different relationship or be on their own, or whether it's because sometimes some of the stresses that contribute to it, dissipate of unemployment and, financial precarity, housing instability, which aren't causes but can contribute, the stresses people have, growing maturity, range of factors, but it does seem to ease after that age.
I'm glad you asked that question because that's what, how before I said I have a question, that's what it was. Because I didn't know that either. I'd never heard that before.
So can I ask, ease from terms of the victim survivor or the perpetrator or both?
Bit of both. We don't really know. Yeah. But when we do prevalence studies, they need to be big, but when you look at the different age groups, you can see that the rates decline after 35. Not like it's not a cliff, but they slope off. Yeah.
I heard that a while ago, and I heard something similar around mental health, maybe not 35, but there is also a decline in severity of symptoms, I guess, of mental health. I heard that a long time ago too, and then when I heard the domestic violence stat, I was like, oh, so curious. And then as a woman, I wonder then around perimenopause and when that kicks in for people, and then what is there then a further decline then? Because if you hear some people talk about perimenopause and menopause as those rose-coloured glasses coming off, or you just have no more capacity for other people's shit, excuse the layman terms language. But yeah, then I wonder about, is there a correlation there too later? Is there a further decline later into perimenopause and menopause for women? I don't know, but
good question.
Just so interesting to think around, all of those kind of nuances and what we know in other kind of practice areas too.
I wonder if there's any research on that, because really, let's face it, menopause was not something that was even talked about 10 years ago. It was, hidden women's business, really. Definitely didn't get the air that it gets now.
No. Yeah. So many like questions and hypotheses, and
it's why you want to become a researcher when you end up working in this area, because your brain just fires off with questions.
Well, yeah, except if you're me.
And you became a researcher, but you just kept a foot in each camp.
I did. That's right. That's true. I'm a much better practitioner than I am ever was.
I think I'm better researcher than I'm much better than a practitioner. So it's good.
Well, we need both. We need everyone. So it's good that, that we have different strengths.
And I think that's one thing about social work. Well, there's lots of things about social work, but I like that about social work, that you can really find your area.
Yeah. So many hundreds of times I've said that to my students.
Yeah. Because it's true. You can go anywhere, really.
Yeah. So one of the considerations for practice is that we don't want to put women in double jeopardy. So, for example, if you ask a woman questions about intimate partner violence and she discloses abuse, you don't want to suddenly be slamming her with a child protection report or have her fear that she's going to lose her child. So you need to have warned her about that. And the other thing that can sometimes happen is, particularly with the antenatal patients who are expecting a baby or have other children, is that they may sometimes drop out of antenatal care. So that's, we need to be super careful about, in particular, decisions to make a child protection risk report. And really be well-founded and not be tempted to do butt-covering reports, or risk-averse reports, but to proceed really carefully to support women so that we're not putting them in that situation.
Well, because we know from lots of research in child protection that the man is still the invisible person in that family. In that child protection response and in that child protection assessment, it's like, what man?
Yeah.
You know what I mean? So, there's always focus on the mother and the role of mothering and what that mother is doing to protect children, rather than focusing on what should be focused on sometimes, which is, what is this man doing to stop himself from being a violent person? Yeah. So, I love that point, because I think if I think back to kind of practice that I can recall, I think that happens all the time. I think somebody makes a disclosure, probably feels like they're in a safe environment. They tell somebody about what's happening. Suddenly there is a child protection response, and suddenly they have people knocking on their door, and then that actually just increases the risk for everybody. So, yeah. But I think if this person can make an informed choice, if they're told whatever you tell me might end up in a child protection report because I'm a mandated reporter, because I have to do this, then they can then make that decision about whether they feel like they want to disclose or not. You know, it's like I feel like it's a double-edged sword, isn't it? Because they're kind of damned if they do, damned if they don't. But at least they're going with a bit of an informed, I guess, opinion around what might happen.
Yep. And a disclosure isn't an automatic child protection report. No, it's up to a worker to think about what's the context, what am I being told here.
Well, I think though in practice, I think it probably is an automatic. It's an automatic, I think. When I think back to my days in child protection, when I think back to kind of working on the edges of child protection for the last how many years, absolutely. If a mother says, oh, yes, he hit me last night, there would be a worker that makes a report about that. I could just imagine that would be the flow.
Yeah, he hit me last night. Yeah, I'm with you. But then it's not always what we do.
No.
It's not always what.
But I guess what I can kind of, I love the fact that you said that then there needs to be some more thought around it. There needs to be some understanding of the context, because I don't think we often see that in practice. Again, I'm talking from my own perception, so people will have a different experience. But from my experience of practice, I think it is about us covering, and I think it is about I have to make a report because I'm a mandated reporter, and they disclose domestic violence, whatever that looks like.
Yeah, not okay.
Well, I mean, I don't think it is okay. But then I think I think on the other hand, what else is this person to do in terms of the practitioner? Do you know what I mean?
I think there are usually options, and one of those is to make really active referral and ensure that they are connected with a solid counselling service that can explore more fully what has happened. You know, how do you become safe? What do you need? And to kind of understand the context a bit better, because those screening questions are incredibly blunt. They're not They're not an assessment tool.
No,
they're just kind of
a screening tool.
Yeah, they're just a screening tool. So you need to then kind of go a bit further and
I would love to know the stats on that. I would love to know the stats on, you know, there's a disclosure as part of the screening tool, and then is a report.
What I found was that it varied enormously service to service, and there would be cultures that set up in different services about, we just do them all no matter what, regardless. We don't ask any more questions.
Yeah, because they've said this.
Yep.
Yeah.
And then I've seen on the flip side skilled practitioners who might use the MRG in our state, or might say to that woman, you know, this is what I'm going to do, but would you like to sit beside me while I ring the helpline?
Yeah.
Would you like to draft something?
Absolutely.
And then the follow-up around active referrals or count, whatever it may be. But also have seen the other where it's just a disclosure followed by a report. I think the practice varies depending on the skill of the practitioner, the service they work for. What you're saying, Jo, is if we had some more, trauma-informed practitioners, we could do things very differently. But again, a continuum, and we'll all sit somewhere differently.
And I think that the introduction of the Mandatory Reporters Guide, which wasn't in place when this health services first started doing this, has really helped in terms of giving a lot more guidance around.
Yeah, if it's used, definitely.
Yeah, that's true, because it's, it is like a standard decision making tool where you can go through the decision making tree to work out what to do. But yeah, I agree, if it's used.
Yeah, so you don't have to use it to make a report in our state.
No.
It's just, interesting though.
It's very interesting. It's very, very interesting, because I think if you were trying to have respectful practice, and I'm not talking about social work practice, I'm talking about general universal practice. I guess in this situation we're talking about a screening tool that's used by health, but those screening tools can be used by lots of different services.
Yeah.
Then you would actually want to have that transparency, wouldn't you?
Oh, absolutely.
Next steps.
Absolutely.
Yeah. Some transparency and some buying.
Yep.
Around next steps.
It's a voice, choice, and empowerment for the woman.
Voice, choice and empowerment. Love that one, Ross.
Something I stole.
Yeah, I've heard you say it before, actually, but I don't
Voice choice? Voice choice.
Voice choice.
Voice
is that.
choice. Oh,
It's part of the principles for being trauma informed.
Yeah, voice choice. Okay.
And I think sometimes it's those things we say, or we say services practitioners say we do, but when you think about that example, it's very easy to see that we don't actually do voice choice and empowerment all the time very well.
So do we think that's the difference between being trauma-informed and trauma-responsive?
Well, being trauma-informed or not trauma-informed.
Okay, so no and respond.
Responsiveness there yet, but just having, and if you're working in child and family, especially in intimate partner violence, I would hope there's a lot of trauma-informed practice going on.
I would hope there was a lot of trauma-responsive practice going on.
See, here you go, Pollyanna. I would too. I genuinely would too. But at least let's start with being, because we know systems can be really trauma-inducing. And it's hard for services to move to being trauma-informed if you think about it holistically, from their policies and procedures to the way the practice works to the way the clients actually feel. Like, there's a lot to it.
There's so many services that say, because it's such a buzzword, isn't it, trauma? Trauma-informed is such a buzzword. There's so many services that would be like, oh, of course we're trauma-informed. We do this, our staff does training, blah, 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 blah. But yeah, they're not responding.
They're not trauma-responsive, or there's parts of the organisation that are actually not trauma-informed. So there might be a good chunk of the organisation, absolutely, that's trauma-informed. But are we from the entire organisation, is everything trauma-informed, starting from their policies and procedures to their work health and safety of their workers and everything in between?
Well, if they're a true trauma-informed organisation, it should be.
Well,
from top down.
My favourite question when I walk into organisations that have that buzzword is, tell me how you're trauma-informed.
Yeah.
And I can tell you the response varies from utter silence, and I've held silence for 5 minutes with an organisation. 5 minutes. Not one person could tell me what trauma-informed meant for them.
No,
or their organisation.
But we did the training.
Yes, well, what did you learn in the training? Because how do I know that still flumps? Longest 5 minutes of my life. 2, organisations that can just go, blah, 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 and you're like, yes, you can see that this is something that's actually the way the organisation is. But I do think it's a word that people attribute to services and organisations, and it doesn't always automatically mean that they are trauma-informed.
This is where I'm like the opposite of Pollyanna, because I'm just guessing. I reckon 80% of services would not be trauma-informed. I think they all say they are, but I just don't think they would be, because I just think it takes so much effort, and I think it is about just using those words, using them as often as possible, putting it out there, using it as a justification in some situations, just kind of using it when it's convenient for it to be used.
It's like being racist. Of course I'm not racist. Of course we're trauma-informed, because it would be awful not to be, but
yeah,
absolutely. If you're not going to admit it, like, no one's admitting that they're racist, sexist, or not trauma-informed. You can't. There's no space for that either.
No,
like, for so many reasons. But
yeah, it makes me feel very sad, though, doesn't it? I just wish there was honesty and transparency, because then everyone could actually move forward. First, you've got to admit what you actually don't know.
And you think about it from a client's perspective. You walk in, you're asked in this screening tool about your experience, and then child protection knocking on your door 3 days later. You can understand from that very non-trauma informed response why then the next time a worker is asking that woman questions maybe around, I don't know, intimate partner violence and mental health, that she's not going to tell the next practitioner a damn word.
God, no, why would you?
All the system has done is trauma, inducing, and said to the woman, mainly the woman, yet again, we don't believe you, or you're not a victim survivor, or, you're responsible for that man's doing.
One of the health services had a lot of fun making a video about how to ensure that nobody ever discloses to you when you ask the screening questions. And when we did the refugee training, we stole it and we just did it as a little fishbowl.
Yeah.
About how to ensure how to ask the questions in a way that no one will ever disclose.
That's right.
Look at your watch and read them out. don't make eye contact.
Yeah.
And it's really nice because initially people are frozen and kind of like, oh, really? These people, is that how they do that stuff? You don't tell them what you're doing. And then the kind of savvy ones start laughing and rolling around and the others kind of catch on.
It's like before Jodie said, when you were talking around when the disclosures come, there's a range of things you do. One of them you said was like, thank you for telling me that. And I had a bit of a giggle because I can't tell you how many times I've seen people do that as a rote automatic. It must be in my training that I must say, thank you for sharing that with me. And it's so disingenuous. And it's I wish you could make a video around that because I'm sure you've seen it too in some of the work you've done.
So much.
It becomes a ticker box on someone's checklist.
Yeah.
Okay, I've got a disclosure. Thanks for telling me that. And you're like, what was that? And yeah, so often I see that.
It's a really good training tool because people can see that it's terrible and they can laugh and it just would put people on high alert next time. Like you can have a lot of fun with that.
You could. I mean, that's what I thought of when you talked about that video. I thought, imagine doing one around the validating and the thanking people for the sharing because I've seen some terrible, terrible work done around that. How not to do it.
Yeah. I would love that video because I think that, I agree with what you're saying. It just can come across where it's just like this statement that has no value, has no meaning.
And it's worse than if you didn't say it because it just says, oh, this person A doesn't give a shit.
Yeah.
It's completely insincere.
Yes.
Yeah.
I mean, there's people I'm thinking of right now that I've sat there thinking, you should have just kept going. You should have not even attempted that disingenuine attempt at validating and you should have just moved along on your tick box.
That's right. Next question.
Yeah.
All right. Well, Jo, can I just thank you so much for coming along and talking with us today?
It was my absolute pleasure.
Well, I mean, we appreciate it a lot and I've learned so much from you. Like I always learn from you, but I've just learned so much from you today.
I think she's been genuine, Jo.
No, I am. 100%.
Oh, I am too. I've really enjoyed it.
Oh, good.
So you'll come back.
Sure.
Perfect.
Time.
Well, we've got a little setup. We know what to do next time.
Yep, it's close to home.
Amazing. We will have Jo back.
Perfect. All right, I think we're finished. Do you want to do anything, Rose?
Brings us to the end of another episode of Relational Practice, a social work podcast. We really hope today's discussion was valuable for your practice. It was for Jodie's and it genuinely really was for mine. And I'm going to change my language from domestic violence to intimate partner violence.
Same, yeah.
I think it's a very good distinction. Lots of takeaways, but that's the number one easy, simple, low impact activities I can take from this discussion. So genuinely, thank you, Jo. To ensure you're always in the loop, please follow our podcast. Your subscription and social media engagement helps us build our community and also make these discussions accessible to others in the field. Thanks for joining us. Please stay safe and always remember to practice relationally.
See you later.
The